like to welcome everybody to today's CSOHIMSS Lunch and Learn webinar. Today's webinar will be Competing on Analytics and will be presented by Mr. Jim Garnham, who is the VP of Consulting Services for NextGen Healthcare. But before I turn it over to Jim, there's a few things I'd like to share about the CSOHIMSS chapter. My name is Scott Mash. This year I'm the treasurer for the chapter. If you do have a question, the way we are going to do questions is you will enter those into the questions feature of GoToWebinar. And then at the end of the webinar, we will take the time to read and answer every question. The CEU form presentation slides, I didn't get these uploaded in time to get into the handouts feature of GoToWebinar, but they will be on the CSOHIMSS website. If you go to Events and Education, Past Events, they're going to be there before the end of the day. We are recording this webinar, and the recording will be available on the CSOHIMSS YouTube channel. If you would like to get in touch with the chapter, our website is csohio.himsschapter.org. You can email csohio.president@himsschapter.org. This will go to Mr. Ryan Clark, who's our current president. If you email csohio.info@himsschapter.org, it's going to go to most of the board. It's probably the best way to get a question answered or to get any information about what's going on. We do try to stay active on social media. If nothing else, we do share information about our upcoming events, our webinars, our fall and spring conference. Just search for CSOHIMSS on any of the major social media platforms and you'll find us. Couldn't do what we do without our sponsors. Computer Associates, HPG, IBM Watson, Cover My Meds. Premier sponsors are OnBase, Nutanix, Crosschecks. We have quite a few elite sponsors as well, but without our sponsors, we couldn't do what we do. So thank you to all of our sponsors. I know we just had some new sponsors that submitted payment and didn't get your logos on in time, and so I apologize to those new sponsors. Now I would like to share some information about the upcoming CSOHIMSS event. The big one for us is our fall conference, which is Friday, October 13th. Title is Interoperability, the Holy Grail of Healthcare. This is going to take place at the Savannah Center in Westchester. It's a big long address to remember where to register. Just jump over to Eventbrite, search for CSOHIMSS, you'll find our fall conference. Register now because I believe the early bird pricing ends in a day or two and you get $15 off. Don't remember exactly what it is, but it's a good deal. So take advantage of that the early bird pricing before it goes away. We are also looking forward to our 11th annual OHIT Day, which is the Ohio Healthcare Information Technology Day. This is our advocacy day where we meet at the State House. We talk about, kind of a core theme, and then we go out and educate the legislature about that theme. We always have a message to share. This is going to take place April 25th of 2018 in the State House atrium. Our spring conference will be at the OCLC Conference Center here in Dublin, Ohio. We're working on the core theme, but if you are interested in presenting, please feel free to contact any of the CSOHIMSS board members or just email at csohio.info@himsschapter.org. We do try to do these lunch and learn webinars every month. Next month will be Humans at Scale, How AI Can Affect Your Organization. It's going to be presented by someone from Crosschecks. I believe Mr. Sean Lane will be presenting. Register at the following link. After that, for November and December, we actually removed the December, but November, January, clear through next year, the dates are open. If you have something that you would like to share, any HIT-related topic, please, please, please contact me, and we'll get you the paperwork to submit a presentation proposal. So now I am going to promote Mr. Jim Garnham to presenter. Jim, I believe we can hear you. I can see your screen. The floor is yours.
Great. So once my computer actually starts to respond to me, all right, well, good. So thank you, appreciate that. Sounds like you got a lot going on, and I appreciate the opportunity to be with you guys today. My title is Competing on Analytics. I do have to tip my hat a little bit to, I've stolen that title from a book by the same name by Tom Davenport and Gene Harris, but the idea behind it is the way we compete in the new world isn't simply just on build a better product or price it differently, but to get a better edge in competition. And the book was on a number of industries, but the competitive advantage is on being able to extract, garner, compile, analyze, and ultimately use data. And companies that can do that can create a competitive advantage. So that's sort of the theme that I'm going on, but I wanted to make sure that if you saw a book by that name, you know I actually stole the title. So, so our primary theme is on using data analytics to drive success in value-based payment models. So the idea actually is if you've been in value-based payment models or you're considering value-based payment models for your IPA or your group, often what has happened up to in the past, up to fairly recently, is a lot of practices and a lot of groups have essentially rolled the dice. And it's, oh yeah, we know we do really great, and so we'll engage with this payer. They want to pay us on value. That's a wonderful thing. But they don't receive any data, they don't do any analytics, and at the end of the year they hope they turn over the card and it's red, or it's black and it's not red. And so what we want to talk today about is really using analytics to make sure that it's red, or make sure that it's black and it's not red. So just a quick note on conflict of interest. I do work for Eagle Dream Health, although we were just acquired by NextGen Healthcare, so thus you see the two logos, but you can read that at your leisure, but you understand what the kind of work that I do. But I will say that most of what we're talking about today, I'm really drawing from my experience within the provider community. So I've spent the bulk of my healthcare career working at the provider level, first for an IPA, a physician organization, that was actually one of the first to become clinically integrated with a advanced advisory opinion from the Federal Trade Commission and DOJ. And then I worked for an academic medical center, but bringing some of that experience to helping that organization move from volume to value. So our learning objectives today, first off, and again, this is a very high level talk, so there's no way we can do any of these things true justice at the level of depth that maybe many of you are hoping for, but we're going to take a pretty high level view here. First off, it's a comprehensive view of healthcare data analytics. I think we all have some understandings or ideas about what that means, but I want to try and take a step back and really a more comprehensive view. At the end, I'm hopeful that you'll be able to articulate the difference between analytics that inform strategy and analytics that we use to implement strategy. So there's two different aspects of it, but you'll see that theme kind of running throughout. Another theme you'll see running throughout is risk adjustment, and there's three different but related aspects of risk adjustment that we'll talk about. And then finally, how to use the knowledge that is garnered from analytics to both negotiate and implement better value-based relationships with payers. So our agenda, I want to take a 3-point agenda. First is very quickly just look at the environment, and it's sort of an environmental scan of where we're at and why these things are necessary and why these things are important. Secondly, a little bit of a look at the technology that is available today that wasn't available even 5 or 10 years ago that makes some of these things more possible. And then where I want to spend the bulk of our time is really the application of it. So how do we use data and information to, number one, know where we are, and number two, then navigate to where we want to be. So another way to put this is understanding the need, understanding the ability and the technology that's there that enables us to do things, and then ultimately understanding how to use that to gain insight into what we want to do next. So on the environment, if unless you've been under a rock, you understand that payers are really setting the pace to value. There has been an all-out acceleration towards value-based payment models, and Medicare has really been leading the way in doing this. They announced back a number of years ago that their goal was by the end of 2018, 90% of Medicare payments will be tied to value of at some form, whether it's in advanced payment models, think the Medicare ACO and similar type models, or some other value-based payment where it's not completely a value or an APM, but there's some sort of tie to value. 90% of payments will be in that, and that's 2018, end of 2018. So I think it's really important that we recognize we're right here. So we're not back in 2014. This isn't some future view. This is upon us right now. As we think about the overall value-based continuum, I like to think visually. So there's a lot of graphics here today, but I think of it really along two margins. One is the ability to engage in population health management activities, and secondly, it's the ability to engage in risk management capabilities. And it's really as we expand out on both of those margins, then we are able to move along the value-based continuum from contracts and financial mechanisms that are really based on rates and volume, which we all know and understand, and it's that hamster wheel of volume, to truly being rewarded for value. And it's based on the distribution and investment and expertise in both of those margins that really determines where we are in our ability to engage in value-based payment models. And we have what I've called an optimization frontier that we can then determine what are we ready for, or what do we need to make future investments for in order to engage. So if we think about the continuum of things, you have fee-for-service at the origin, really doesn't require a whole lot. And then there's quality incentive programs like pay for performance, pay for reporting. You really need a quality focus, some quality improvement. There's a little bit of risk involved, but not a lot, but that's where a lot of people are right now. And then as we move out further, beginning to take partial risk for things, whether it's gain sharing, which is an upside only, you only share in a portion of the gains if there are any, or bundled payments, which may have both upside and downside, but they're limited in scope, maybe to 1 or 2 service lines, and then all the way out to a full risk where there's either upside and downside, or global capitation, where essentially you have a budget and you work within the budget, and if there's money left over, you keep it, and if there isn't, that's on you. And some providers are even going as far as forming their own health plan to bring all of that in-house. So that's the end of the environmental scan, if you will. But if we then think about the technology, when I started in the provider sector, which was back in 2005, there were very few providers that were using electronic medical records. Hospitals, a lot of them had homegrown applications. Most of the providers, at least that we worked with, did not have one. As a matter of fact, when we went through our clinical integration program, we knew that this was important. We said, we'll pay you, we will pay to put an EMR in your office. And you think if somebody did that today, they'd be beating down the door to get the money. Back then, only 2 practices out of the dozens in the IPA took us up on it, and most just had no interest in doing that. So we've come a long way in the last decade. The other thing we've done a lot of is back in the early days, if you recall, much of the EMRs, they were really just electronic versions of the paper record. There was a lot of scanned data, scanned documents, but it wasn't really structured data that allowed for analytics. That has changed significantly in the last few years. And then finally, again, if it's just a scanned version of a paper record, there really aren't tools that enable you to revise your workflows. That has also changed within the confines of most electronic medical records. There's a lot of tools that are available to support workflow changes, both within the office and across offices, or with collaboration with other providers. So again, I've just thrown some charts in here just because I like visuals, and just to see the stark increases in EHR adoption. The other one that I found fascinating was this map, and that's 2013, is a number of years ago, but just the rapid adoption of e-prescribing within a physician network. And so it was back in 2007, 2008 when I was at the IPA, and we were presenting actually to a HIMSS group back in 2008 to talk about our e-prescribing initiative. And at that time it was extremely rare that anyone was using those tools, and now, especially now that even controlled substances now can be e-prescribed, the ubiquity of e-prescribing tools has really grown significantly in the last few years. So a lot more technology that's available. The other thing is data aggregation and health information exchanges, RIOs, whatever you want to call them. Back in 2015 was the latest study that I was able to see. There were 165 public HIEs, 277 private HIEs, the public ones, I think, have long struggled with a sustainable business model. When you're grant funded, a lot of times you do a lot of different things that you wouldn't necessarily if you were market driven, and so they're struggling to have a sustainable business model. But the private HIEs have really taken off. The primary point here is that HIEs are here and they're functioning, and they are allowing information to flow from one provider with one EMR to another provider with another EMR, even if they're not associated through either an IPA or an integrated delivery network. But they allow for aggregation of data from across multiple sources, as I say, clinical. Also, some are multi-payer claims data repositories that allow for that data to flow, or patient-generated. So there's a lot more information that's available to be used for analytics that wasn't just a few years ago. And I chuckled in the intro. We were talking about the fall conference, October, I believe you said is October 13th. True interoperability still remains elusive. There is still not the we've been talking about this for a decade, and it remains outside of our abilities quite yet. But I keep saying every year, every time I do something like this, I keep saying it's right around the corner. I do believe it is, but the true interoperability of bi-directional communication into and out of an EMR across an HIE, I think is really where we're going to be able to accelerate these things even more. And I just threw up another quick graphic. Just the basic point here is that over half, or roughly half, of physicians say that they regularly have exchanged information with other providers across something other than their own EMR. So that's a significant change in the last few years. And then there's advanced analytics capabilities. If you follow any of the rating agencies like KLAS and some of the others, you've seen just an explosion of reviews of companies. A lot of them are very, very new that do and are focused on healthcare analytics, particularly to support value-based payment models. And it begins with performance metrics, just reporting. There are a slew of folks that all they do is aggregate data and report to, whether it's a payer or the federal government, just to enable those value-based payment models. And they're expert at it, and they do really well, and they're really efficient. And that's all well and good, and that's great, and that's necessary. But then we need more than that. And so if you talk to any physician for more than 5 minutes and you talk about metrics, then of course you understand the value of risk adjustment. My patients are sicker, I have a different selection of patients, I live in the city, I live in the country, whatever it is, it needs to be appropriately risk adjusted so that it's fair, whether it's for compensation or just a quality score, it needs to be fairly risk adjusted. And those technologies and capabilities have been growing. But then the one that I think is really where the rubber meets the road is analytics that allows you to identify and target limited population health management resources. I was working with an IPA just recently, and we were working with a payer that wanted to engage. He wanted to engage with a value-based payment arrangement, and the sticking point between the IPA and the payer was that the payer didn't want to pay for care management, and it became a barrier because the obvious point was, well, unless there's funds, I can't just go out and hire somebody and not have reimbursement and only get reimbursement on an if-come basis to pay somebody's salary. So we have to have ways that we can target those limited resources to the places where they are going to be most effective in producing the outcomes that we're looking for. So I would kind of frame this entire talk with, now that we have all of this technology, are we really asking it the right questions? And so if I'm going to think about what are the right questions, then I want to frame that in terms of what are the right questions for what's necessary to be successful in the world of value-based payment models. And if you think about the formula for value, typically what they'll say is it's quality plus financial outcomes, or quality plus access over the financial outcomes or over cost. All of those things are really important. And so first off, obviously we need to improve the clinical quality of the delivery system. So improve that through the identification of best practices. So where are we doing really well, and how can we make sure that everyone is doing really well with respect to whether it's a diagnosis or a particular condition. And then, as we alluded to earlier, it's that data-driven care management. So it's who are the people that we can intervene on who really need that intervention so we can apply those care management resources most effectively. And how do we use those things to improve quality? On the efficiency side, then it's identifying and eliminating low-value care. What things are not producing quality? What things are we spending money on that are avoidable? You think of the federally defined avoidable hospitalizations or potentially avoidable hospitalizations, potentially avoidable ED visits. Those are hot topics and metrics that the federal government is looking at. And those are the kinds of things that we want to focus our attention on. Where could we have avoided a hospital stay or an ED visit or a facility-based rehab visit or those kinds of things? It's reducing unwarranted variations. The key there being unwarranted. It's things that, we know variations between individuals may cause certain differences in their care and their outcomes, and that we understand, but where it's not based on clinical differences or patient differences, but it seems to be random or potentially it's because of biases in the care patterns within a particular geography or practice. Those are the kinds of things that we want to target. And then ultimately we want to improve our reimbursement. And that really gets us to the sustainability argument. We want to create an environment where not only are we improving quality and improving the cost performance, but we actually have the commitment of a highly effective collaborative group of practitioners that are committed to this. And again, it's when you focus on high quality and not just low cost, that certainly helps. And that patients and physicians and staff are all satisfied with the delivery. If you're thinking about the quadruple aim, it's improving quality, reducing costs, and it's patient experience, but also physician and staff experience. And at the end of the day, what we're creating is a sustainable business model that now provides the revenue that we need to support the investments in those innovations that aren't fee-generating activities. So, right now, if we're in strictly fee-for-service, the only thing that's going to generate revenue is fee-based activity. And if we want to move to value, there's certain things that we have to do that are not fee-generating activities. So we've got to have a model that sheds additional revenue so that we can afford to make those investments. Otherwise, it's dead in the water. So I like to think of this as really kind of a two-pronged approach, if you will. And you'll see this theme kind of throughout the rest of the talk. And first is, we need to understand where we are. It's what are our clinical opportunities? Where can we improve that those clinical outcomes? And as we think about the financial aspect of it, where can we improve that value proposition? So as we approach a payer, we can say, look, not only are we good quality, but we've got lower than average cost. Here's our value proposition to you. We can help you save money if you engage us in a value-based relationship. And as we think about those kinds of things, and this kind of gets into what I was referring to as sort of the three different kinds of risk. The first kind of risk is descriptive risk, where essentially what we're saying is if we look backwards at our outcomes, our clinical outcomes and where we have opportunities to improve, and even the value proposition of where are we overspending now, we're looking back to say, this is what was done in the past. Help me to understand, based on a risk adjustment model, why those things occurred. So, for instance, somebody had a heart attack, they were a diabetic, they had a heart attack last year. Well, that then explains why their expenses last year were higher. That's a descriptive risk. It's looking backwards to see what explains why costs are the way they are. The second focus then is to manage where we want to go. So that's things like setting performance goals. Now that I know where we are, now I can look to see where do I want to be, where do I need to improve. I can track our progress, trends, gaps in care, gaps in services. And this is really where we get to that focus on how we can apply those limited population health management resources to where they're actually going to have an impact. And our second form of risk adjustment, if you will, is predictive. So if understanding where we are means I have to look backward to where we were before and what explains that, a predictive risk model says, okay, given where I'm at today, what are the things that could happen in the future? And those are the areas that I now want to focus my attention on. So if I go back to my diabetic example, somebody has diabetes, they have high blood pressure, and their A1C is really high. They haven't had a heart attack, but they might be at a high risk for heart attack. So instead of the person that had one last year and explaining why their costs were higher, now I'm looking at factors to say this person's at risk for a heart attack, they're at risk for high cost, that's where I want to focus my attention. So the next section I want to talk about then is within the confines of our application of this is really three approaches. And the first approach is this care management or care navigation. And it's that, as I said, that focus of these limited resources. So again, going back to this understand and manage framework that I set up, is understand first off, where does my practice have gaps? So if I want to put myself in a position of a practice manager or a practice a leader, and understanding where do we have performance gaps. Look at those clinical quality metrics. We have a contract with the Blues, we have a contract with Medicare, we've got this list of metrics. Where are we falling short in performance? And even at the physician level, individual physician level, they may be saying, you know, I don't even care about the contract. I only care about my compensation. My compensation is tied to these 5 metrics. So where are those metrics? Which one of those am I not performing well on, and what do I need to do to improve it? And that, which then gets us to the managed part of it. So it's what patients, who specifically do we need to engage to fill those gaps? So it's goes from an overall picture of the practice or picture of a physician's performance on what the areas, the quality or financial areas are that, that need attention. But then in order to implement something, to actually change that, we need to get right down to the specific patient level to say, which patients are not meeting goals? Which patients do I need to intervene with and prioritize on so that we can move the needle to where it needs to go? So what you need then are triggers. And the triggers really come in 4 ways, or we'll say 4 different types of triggers. One are metric specific, so it may be a certain diagnosis. So somebody had a newly diagnosed malignancy, newly diagnosed dementia, those kinds of things are a trigger to say, oh, this is somebody that needs attention. Another trigger might be, again, specifically from the metrics. I look at those metrics and I see I'm only at 80% performance on my diabetes screening. Well, who are those 20%? And let's get them in, or let's do some outreach. Maybe I can have the nurse, or we can bring in a diabetes care manager, and they can focus on how to get folks to do the things that they're supposed to do. But it's a way to, it's that trigger is they're not meeting the target. That says this is somebody that needs attention. And so again, you need some sort of a dashboard that says, here's where we are. I like the red and green because it's easy to look at, easy to see where the goal might be, and are we above or below the goal. But then it needs to be drillable into a patient-specific list so that we can actually implement it, operationalize it, if you will, to improve care. Here's a whole bunch of people that have, in this condition, there's hyperlipidemia is one of those listed. And so those, these are folks with hyperlipidemia that aren't meeting the hyperlipidemia goal. So now I've got a list that my care manager can start to work to intervene to make sure that they're getting the care that they need. And then, of course, no process is really complete without being able to track, is it making a difference? So trending is really important. Are the measures that are supposed to be increasing actually increasing? Are the ones that are supposed to be decreasing actually decreasing? Are we going in the right direction or not? It's that continual feedback loop that we need for really any process. Second kind of trigger is a gap in care, and I would differentiate gaps in care from not meeting targets is specifically just patients not getting something. So not meeting a target might be their A1C last time was 9. That's not meeting the target of under 8 or under 7 or whatever your metric says. But if they never didn't have an A1C test to begin with, obviously then that's a gap. They need to go and do that. And so again, you need some kind of a dashboard that says, here's people that are due or that are near due. So this is sort of that next level of analytics. It's not just looking at folks that don't have the test and are overdue, but hey, you know, here's a whole bunch of people that are going to fall off the metric in the next 30 or 60 or 90 days or whatever it is. So let's do some preventive outreach and say, hey, you know, you're due for your A1C test or you're due for your eye exam. Why don't you make that appointment, or can I help you make that appointment? Or you haven't seen them at all. So we've had some practices that I've worked with that had no idea that they had so many folks that were on their roster that they're the primary care provider in the banner on the electronic medical record, and they haven't seen them in 2, 3, 4 years. You know, that's particularly if you're now haven't been seen in 24 months, and you put that with they're over 65 and they have 3 chronic conditions, that's a potential disaster. So the third trigger is event triggers. So if you think about, somebody going into the hospital or into the ED. That's an event trigger. And thinking back on the HIE discussion, some of the RIOs and some of the HIEs have triggers like that automatically will communicate to either a network or a provider, and they're doing pretty well at getting the right person contacted, at least the right group contacted, but there's triggers within the systems that say, hey, your patient just hit the ED, you should probably reach out. Or moving from hospital to, say, a facility-based rehab, or going into hospice care, those kinds of things. So transitions, as we know, transitions of care, which is that's a webinar all unto itself, but transitions of care really is a key place where balls get dropped, medication reconciliation doesn't happen, communication doesn't happen, and particularly if you're their primary care provider or you're their specialist that is following whatever the condition was that they went into or out of the hospital for, it's very important that you be on top of those things as much as possible. The other kind of event trigger is a pre-visit planner. So if you think about, hey, who's coming in this week, or first off, let's start with who's coming in today, and we have the daily huddle, and we can talk about who's coming in. Wouldn't it be great if you also knew at that time, you know what, they've got some gaps, or they're overdue for something, or the last A1C was this or that, or they have risk flags, and we'll talk about that in a little bit, but we can sort them by risk or sort them by number of conditions and say, you know what, Mary Smith's coming in at 10, we need to spend a little extra time with her on some of these things because some of these things need some extra attention. Just being able to plan that visit a little bit better, but again, based on data, not walking in and reading the chart as you're walking into the practice. And what we found with some practices that have used things like this, and this is what we were doing back in my IPA days, we had built something very similar to this, and initially it was all about who's coming in today. Let's print that sheet off and who's coming in today. Eventually practices started printing off those sheets and started looking at that stuff 2 days, 3 days, a week, sometimes 2 or 3 weeks in advance, because then they could reach out to folks and say, hey, you're coming in 3 weeks, and we'd like you to have this or that test done, so then we can review it with you in the meeting, in your appointment, which is a whole lot more efficient, both for the physician and for the patient, than to have them come in, send them for a test, then have them have to come back. Again, if you're at risk for those dollars, that's a value argument. If you're just trying to churn volume, then maybe you don't care. It's just another visit. I need the volume. Finally, the final trigger is risk flags. So we think about profiling patients, and I don't mean that like, we're profiling them to do a security screen at the airport, but we're profiling patients for intervention. Who needs more attention? Maybe they have a diagnosis or signs and symptoms of frailty. They're maybe elderly, or they have certain other conditions. Or, as we talked about with the medication reconciliation at transitions, there's also an issue of medication compliance. So folks may be on 8 medications, but guess what? They've only filled 3 of them. That's an issue. Or care density is one where are they getting their care from a group that's affiliated, or do they have their primary care with one network and they have a cardiologist with a different network? And used to be in HMOs, you all had to be in the same network, and now with PPOs, you can kind of go wherever you want, which certainly adds a lot of flexibility, but it also creates this lack of continuity across the continuum of folks that are caring for you, and can cause, not necessarily, but it can cause lack of clear communication and can cause issues. Whether it's complexity, just the whole complexity of your conditions, that's a reason that we need to pay more attention. Moving away from the individual level, kind of moving up to more of a network administrator level of things. Another approach to using analytics is in practice pattern variations analysis, or PPVA. And essentially what we're talking about is, can we look at patterns of variation with specifically, let's say, a particular condition. So again, I'll use diabetes as an example. We'll look at diabetics, and can we see the variations in cost, and then can we get at, you know, what's driving that? So where are there opportunities to improve those care patterns, whether it's cost or quality or both, and then what can we do to achieve those improvements? Now, I have to say, you know, this is where I say that you know, someone like me, that I can help set up the analytics and looking at the right things, and that's great. But that's where my role in this has to end, and the clinical role really has to pick up, because you can't have a bean counter like me talking to a physician to say, you know, you're at variance to the standard care pattern for the treatment of diabetes. And if you're a doc or you know one, you know that's not going to go over particularly well. This is about improving quality, and you have to focus on that. And practice pattern variations analysis, in the experience that we've had with it, has really been an opportunity for the engagement of specialists in population health management activities that, unlike with primary care, where most of the metrics and most of the contracted metrics are primary care focused, the specialists a lot of times are kind of left sort of to their own devices, if you will, and a way to engage them in things is engaging them in things that they really care about. And so you start looking at practice pattern variations across the network and things, and you can really begin to have those kind of conversations that really can become fruitful. I found this this next graphic from an article. I found it quite fascinating, and it talks about the reasons why clinical decisions are made, individual clinical decisions, and I noted that about 50% are not based on studies, randomized clinical controlled trials, those kinds of things, but it's what they call arbitrary or instinct or experience and anecdote. And I don't mean to downplay the value of a physician's instinct or their experience, or even anecdotal evidence of, you know, I know what I've heard other, you know, people say is in the studies, but, you know, the anecdotal evidence across my colleagues is different, and that should come into the decision-making process. So totally understand that, no disparity there, but it is evidence of why there is some variations that are really not based on clinical evidence, and they may be more arbitrary, and therefore why variations that need attention do exist. So as we say, you know, if we're going to, now that we've identified that there are variations, then okay, then how do we then, you know, what do we do about it? So, you know, it gets back to that whole, are we asking our analytics the right questions scenario. So, you know, again, there's what are the high cost conditions that have the most variability. Again, is it properly adjusted for risk? Because we all know if it's not adjusted for risk, then nobody's going to pay attention to it. And then once we figure that out, there's what are the clinical cost drivers? So does it add value or does it not? And this is really then comes down to the whole, is it clinically appropriate question. And then once we have that, then we can, once we know is it appropriate or is it not appropriate, and if it's not appropriate, if it's not warranted variation, then we have to figure out then, well, what do we do about it? So if I go back to the diabetes example, one of the things we looked at was Januvia, and it was a huge variation in the use of Januvia, and it had a huge impact on the cost. When we got down below the surface, what we were recognizing was that those providers that were using Januvia, they were using it appropriately. They were using it on high-cost individuals that other factors and other interventions weren't working. And so that was good variation. In another scenario, we had, this was back a number of years ago, Lipitor, which was very expensive at the time. There was no generic then. And we looked deeper and saw it was just random. It was practice preferences, but it had nothing to do with the patients. So we moved folks to simvastatin, saved tons of money. 2 years later, everybody was still on simvastatin. Doctors were happy with the progress, and we removed that variation, and it had a huge financial impact, both for patients and for the group. And I just threw up some information here about what it takes. You need large databases and those kinds of things. But really, the focus of this slide is really that last bullet. It's focus on quality improvement. It's not determining who's best and who's worst. It's let the data speak and open up some possibilities, and really it lays the groundwork to have the kinds of conversations that really only doctors can have with other doctors. And so just as an example, we had, and I won't even get into the clinical aspects of fiber optic laryngoscopy and ENT, but essentially it was, we looked across the spectrum. There was huge variability. We simply had the conversation, and after having that conversation, without really incentives or anything else, it was just exposing the variability, we reduced utilization of a very high cost procedure by over 11%. So, final approach, risk adjust for payment, and I know we're coming up on time. We're almost done, and if we think about if you're at risk for a population, so we're now down out in that far upper right quadrant of the value continuum. You're at risk. You may have a budget that's based on some factor, whether it's a prior year cost plus a trend, or it's a percentage of premium, or whatever it is. It really needs to be risk adjusted in order for that to be a viable budget for you. So if it's risk adjusted, typically that risk adjustment is based on diagnoses. And it's diagnoses that go into claims, because the payer, all they have is claims diagnoses. And so you can understand then why it's important then, if diagnoses are being treated for and addressed, that they be in the claims data, because otherwise your budget isn't going to appropriately reflect the level of severity or level of sickness in the population that you're treating. So, and again, I go back to the whole risk adjustment part of it. We said in the risk adjustment that explains why things were expensive in the past, that's retrospective, but this requires predictive, prospective risk adjustment, because all I know is the conditions that have happened in the past. What I'm trying to do is project what might be in the future, and that's what I'm going to use then to risk adjust my budget. And I've seen in the past, more often than I care to admit, where providers were getting into risk-based agreements with payers, and they were using retrospective risk adjustment to adjust their future budget, and those things don't work. You're not looking at the same things. You're not looking at the chronic conditions that are pointing to future expenses. You may be looking at an acute event that happened in the past that may or may not have anything to do with future expenses. So, as an example, Medicare adjusts the risk-adjusted premium that it pays to Medicare Advantage plans based on diagnoses that show up in claims. There's a whole series of ICD-9 or now ICD-10 codes. Over 3,000 of them roll up into now the new model 79 hierarchical condition categories, or HCCs. Each one assigned a risk score. You add them all up, it becomes a weight, and you multiply by a premium. So that's why it's very important that as much as is appropriate gets in there, because that's a multiplier that then determines the premium that comes to the plan. And of course, if you're at risk with the plan, then if it's a percentage of premium, as their premium goes up, so does your budget, and it improves your bottom line. Now, a couple of nuances of how HCCs are calculated by CMS. It's really all prior year. Again, this is why it's a prospective. It's prior year diagnoses, and it's only something what happened in the prior year. So we joke that Medicare is the only payer that thinks that if you didn't claim anything for the amputation for the diabetic in the last 12 months, Medicare thinks that the foot grew back. Obviously that didn't happen, but the way it works within their risk adjustment system, it's as if it did, because if it didn't get claimed for last year, it doesn't show up in this year's premium. So, how does it work? What's our strategy? Well, it really revolves around sort of the schedule of how, and this is just Medicare, but again, if you were doing this with a commercial payer, it would be something similar. But if we look just at the focus on the table at the bottom, for premium rates that start in January of this year, it was based on claims for services from July of 2015 to June of 2016 and submitted and received by CMS by September of 2016. Then they adjust again. So in March of 2017, they would have moved that baseline of services up to a full calendar year of 2016. So now you think about, well, what does that mean? Well, if something that had a really high score was a service that was in December of 2015, my rate in January would reflect it. My rate in July all of a sudden won't reflect it because it happened in December of 15. These things just drop off. And then, of course, then there's a final adjustment in January of 2018. It gets paid out actually in about August, July or August of 2018. So our strategic approach. Now, what do we need to do? Well, first off, we need to figure out where are we. What are those HCCs? What are the weights? What does that look like? And then we need to begin to mine historical claims data. Look for things in the prior years that may have been dropped. They were there before. Did the foot grow back? Was there something in the past that may be relevant to the current that you've been actually treating, but has never showed up on a claim, or as is relevant in that January to March time frame when the baseline moves for HCCs, something might drop off. And do we need to make sure that we are addressing that again this year, in this calendar year, to make sure that it doesn't drop off next year? And then also, one of the biggest opportunities that we found was in severity. I don't know ICD-10, but ICD-9 diabetes was 250. Well, everybody writes 250 because that's all you need to justify the A1C test. But if they have not diabetes with nephropathy, it's 250 point something something. And that's relevant to the risk adjustment, not relevant to the claim. And so in the end, really, there's kind of catch-up work that we need to do the analytics for. We need to update our diagnoses when patients come in, look and see where there are opportunities, and make sure that they get coded appropriately. There's ways to then work with a payer or consultant to also mine that data to look at maybe some supplemental submissions, which are also possible. But really, the gold standard is changing the documentation patterns going forward. And you're never going to do that unless you have the data in front of you that says where those opportunities are. Okay, last slide. As I said, there's 3 types of risk adjustment. One being descriptive, looking backwards, things that happened, as I said, the diabetic that had the heart attack, that explains why costs were high. Predictive was, now I have a diabetic, hasn't had a heart attack, but he's got a whole bunch of risk factors for when I can intervene, identifies where I need to focus. And really sort of that holy grail is in the preventive. He's not diabetic yet, but he's got all of these different symptoms, and he's got pre-diabetes or whatever we want to define that as, and that gives me the ability then to do some outreach and prevent the diabetes from occurring in the first place and prevent the heart attack from ever happening potentially years before it might have. And if we think about long-term value-based payment models, that's really the secret sauce. Otherwise, we're constantly chasing our tail. This is really where analytics it becomes so much more valuable for value-based payment models, is when we begin to kind of roll that clock back further and further and begin to prevent things from developing in the first place. All right, I guess sorry, that wasn't the last slide. This is the last slide. So we start with data. Obviously, bringing data into information is critical. That's what then, as we garner information from our own clinical data and from claims data and from patients' provided data, that begins to then say, what are our strategic value-based priorities? Where do we need to focus our energies? And then from those priorities, then we drive a patient list right down to the point of individual patient to provider care management. Or another way to think about it is, data and information drives the building of our value-based priorities, our value-based strategy. From that value-based strategy, then we drive individual patient care, and it's analytics that's at the core of that move from the data right down to the patient care. But here's the kicker: it's really bi-directional. So the strategy through analytics drives patient care. It's also true that patient care, and as we gain experience through analytics, then is that continual feedback loop back up to revising that value-based strategy. I took Scott's advice, and I did have that second cup of coffee this morning, so we did get through it in time. I hope this was helpful. I'm certainly happy to take questions.
Yeah, we did get a couple questions that were submitted. The first was, didn't the government really use a stick and carrot to get physicians on board because physicians were more or less forced to get an EHR, and it wasn't because of the value that might come from them?
Yes, absolutely. And so, we've had certainly a lot of folks that have gotten EMRs and have gone the meaningful use route, not because they saw the value of it, but because they were being paid to do it. Absolutely. Quite frankly, doesn't really matter in that sense. Now that we have the technology, again, it comes back to my initial question. Now that we have the technology, regardless of why we have it, are we asking it the right questions so that we can get the value out of it?
Okay, and I guess the second and last question we had entered was, can another provider's care, such as a consultant or a specialist, affect the referring doctor in outcomes data mining?
Absolutely, it can. And so this comes down to the whole principle of clinical integration. So if you're working with a network, and let's say I'm a primary care provider, and I refer my patient to Dr. Smith, who's a cardiologist, if that cardiologist isn't caring well for my cardiology patients, that could end up dinging me in my compensation, because it dings my metrics. Absolutely. This is why it is so imperative, and why I try to focus throughout the presentation of their need for early collaboration and involvement with the clinical network, to say that this has to be clinically driven. It can't just be the financial bean counters like me, but there's got to be a collaborative approach in this, where it's doctors getting in the room with doctors. One of the things that in my IPA experience we found that was really wasn't what we expected. It was one of those serendipitous moments. Was when we were building the condition guidelines. So care for diabetes, care for heart disease, care for whatever the condition was. We developed like about 45 or 50 of those. And we brought in both primary care and the relevant specialties and subspecialties into the room and said, here's a national guideline, here's a local guideline, discuss that as a network. And it got that those collaborative juices really flowing. And it really then began to say, what are those things that are fair to set as goals and targets and to hang dollars on? So what measures should a primary care doc be accountable to? What measures should a specialist be accountable to? Having those conversations and those kinds of interactions creates a tremendous amount of glue that helps these things stick together.
Well, Jim, we are over time. I thank you so much for serving as a presenter for our Lunch and Learn webinar series. And attendees, thank you for sitting in on this webinar. And there will be another session again next month. Look on the CSOHIMSS calendar on the CSOHIMSS website. And Jim, I hope to hear from you again.